All right, team. Trying something new here. I know a lot of you sometimes don't get to see me, especially on night shift. So trying something new. See if this YouTube stuff kind of works out, and if you guys enjoy it, you can provide me feedback and see exactly how effective this is in communicating. Because I seem to bombard you with emails, and I think it's sometimes easier to hear just straight from my mouth. So I just wanted to put out a couple important notes in regards to some of the things happening here. The email will kind of reflect that. If there's any cracks on the doors of the IV pump where we actually put the tube in, apparently these cracks in the inside of the actual device can lead to the patient receiving bolus doses of whatever medication or whatever fluids you have on. So if you notice that any of these doors have cracks in it, don't use the equipment. Mark it as basically a deficient piece of equipment. You could just say that it needs to be fixed, and then place it in room 75 and let me, myself or Sergeant Wooderson know. From now on, apparently something happened at MedCom level, and any wristbands that have allergies on it, typically our practice has been to write the allergy of the patient on that label. They do not want us to do that anymore. So we need to make sure that we're just placing the allergy label on there, and we have to verify with them if they have that, what their allergies are to, and make sure that the system is reflected. The same thing is going to happen with the falls wrist, but I usually don't see many of us writing the falls wrist on. I know we only have the yellow bands right now, but we should be actually getting bands that say fall risk on it shortly. Ms. Fuller is going to begin to do some testing for the Braslo tape. It's testing that all personnel on 4AB are going to need to have, especially anybody that has direct patient care. The training is still on SWANK. About 90% of the employees have done it. If you haven't done it, please do the SWANK training first, and then she's going to do a quick 5-minute test out on everybody, and then we'll get our competencies for it, and then we'll put it in our folder. As far as the RRTs are concerned, I know we had a couple RRTs this week. They haven't gone ideal. The overhead page, especially at night, has not been reaching the ICU and the providers. So what they're asking is, when we do activate RRTs, to make sure that we are contacting the provider directly as well, to make sure that they are aware that the RRT is occurring. And if for some reason there is RT, so if respiratory therapy needs to be on board for anything that's happening, they have a 30-minute response time that they have in order to respond to an RRT, a code, from the hours of 2300 to 0700, because they are not in house. They are telling me that they should reply to any of the codes, and the number I provided to you as far as the pager number is concerned, I provided to you in the email as well. So they say that they will respond to that page in an appropriate time, and they'll assess the situation, and they'll see if they need to come in for any interventions. There was an instance where Ms. Miller was asked to go to the ICU this week because of RRT to cover their patients, because they didn't have enough people to come and cover the RRT if they left one nurse in the ICU. It's currently being worked by leadership. That didn't make much sense. We've engaged it all the way up through the DCN, and we're currently coming up with a way to not have that happen, because it doesn't make much sense to take the nurses that are capable of taking care of the patients and have been with the patient for the majority of the shift off the unit for a nurse who has very little knowledge of the patient to come and intervene. Didn't make much sense to me, and hopefully we get that stuff ironed out in the future. Just to let you know, there's probably going to be a Code Pink exercise. So I am going to attach the Code Pink protocols. In short, we're supposed to man both exits. We only have two. We have one entrance and then that exit at the back of the hall. We're supposed to go there, not let anybody in or out, and we're supposed to search all our rooms for an infant. If we, for some reason, find an infant or the child in our area, we're to call the AOD number and notify them that we have it, and then they will activate the MPs and shut down whatever they needed to shut down as far as their activation or de-escalation protocols. And then we would maintain the child until the doctors get here. The doctors would then take the child to the parents, and we'll have successfully completed that exercise. Other than that, we have a couple other things coming down. Hopefully the schedule has started to resolve for many of the issues that we had. Night shifts specifically, I've really focused on making sure that there's multiple days off in between your work schedules, and that we've provided a medic for you starting next week. Continuously throughout the week, you're still going to be down the medic on the weekends, but we are going to have a medic Monday through Friday for you guys, which is typically our busiest times as far as patient care is concerned. If there's any other issues, please bring them up. I'm going to try to do these a little bit more frequently, and especially if you guys have positive feedback from them. Thank you for your time.